good morning, guys. I hope everybody's doing well, and thank you for joining me today. Today, we will be talking about another endocrine disorder, um, and we will have a little bit of comparison between hypothyroidism and hyperthyroidism. So, a lot of questions in NCLEX. Talk about the difference between these two disorders. But before we actually try to differentiate the signs and symptoms and possibly management for these two endocrine disorders, let's look back at the anatomy and physiology of the thyroid gland. And you know, I always use anatomy and physiology as a springboard for discussion. I believe that if we have a good grasp of the normal anatomy and physiology, it will be easier for us to understand deviations from normal. Anyway, so um, your thyroid gland is a small gland hugging your trachea. It's a butterfly-shaped gland um, located in front of the neck. It hugs the trachea. It produces thyroid hormones, and there are three thyroid hormones produced by the thyroid gland. Actually, you have the T3 or triiodothyronine, and of course you have the T4 or the thyroxine. T3 is more biologically active, and these two hormones are necessary in order to produce adenosine triphosphate or ATP, which is energy of the cells, and needed for cellular metabolism. The other hormone produced by the thyroid gland is called calcitonin, or sometimes called thyrocalcitonin. Thyrocalcitonin or calcitonin is important in controlling the calcium level in the blood. So any excess in calcium or serum calcium level will be monitored by the thyroid gland, and if there is an excess, then calcitonin will be released in the blood, causing deposition of calcium from the blood into the bones, thus reducing the calcium level or serum calcium level, preventing hypercalcemia. Um, so again, these are the three thyroid hormones secreted by or released by the thyroid gland. You have the T3 or triiodothyronine, the T4 or thyroxine, and of course your calcitonin. All of these hormones released by the thyroid gland, or the release of these hormones from the thyroid gland, will be triggered by the release of the thyroid stimulating hormone coming from the anterior pituitary gland. And of course you have the TRH or the thyroid releasing hormone um, coming from the hypothalamus. So it creates a domino effect. When the hypothalamus releases the thyroid releasing hormone, then the anterior pituitary gland will release the TSH, causing a domino effect and triggering the thyroid gland to release T3, T4, and your calcitonin. So, what's the function? Earlier, I said, T3 and T4 are responsible for producing adenosine triphosphate or ATP, and this ATP is necessary in the cellular metabolism. ATP is utilized by the cells as energy or as a fuel. An increase in adenosine triphosphate means that the cell will have more energy to utilize for cellular metabolism, and more ATP production, more energy production will mean an increased heat production as well. So, in essence, an increase in T3 and T4 will cause an increase in cellular metabolism, and the flip side is if you don't have adequate amount of T3 and T4 release, then not enough ATP will be produced, and so the cellular metabolism will decrease, causing decreased body metabolism as well. The other hormone released by the thyroid gland is called calcitonin or thyrocalcitonin, and it has several effects in the body. The number one effect of calcitonin release is um, any excess calcium level in the blood or calcium in the blood will be deposited to the bone by calcitonin. So the main function of calcitonin is to really um, detect any increases in the serum calcium level, and if there is an increase, then calcitonin will deposit those calcium as minerals of the bone, causing stimulation of more osteoblast formation, causing strengthening of the bone. So the more calcitonin you have, means that more calcium will be deposited into the bones, and so therefore the bones will become stronger for that. The downside is calcitonin will cause lower calcium level simply because of the deposition from the blood to the bone, and then it also inhibits the absorption of calcium in the gut or in the intestines. So calcium will not be reabsorbed in the intestines, and that can cause decrease in the calcium level in the blood. And also calcium will be excreted in the urine if you have adequate or too much release of calcitonin in the blood. So too much calcitonin can really cause hypocalcemia simply because you don't have reabsorption of calcium in the gut with calcitonin, and calcium will be excreted through the kidneys as well, through the urine with calcitonin. So it's good because it will cause strengthening of the bones. But on the other hand, you have to watch out for signs and symptoms of hypocalcemia if you have oversecretion of calcitonin, and hypocalcemia can have deleterious effect as well. Of course, you have your involuntary muscular contraction if you have hypocalcemia, you positive Chebyshev sign, and you have the positive Trousseau sign. So we need calcitonin in order to strengthen the bones and prevent um, too much calcium in the blood. But on the other hand, it has to be controlled. Otherwise, it can lead to hypocalcemia that will have some negative impact on the body as well. So T3 and T4, two hormones produced by the thyroid gland, and these are basically responsible for production of energy in the form of adenosine triphosphate. T3 is more biologically active. There's a hormone, or there's an enzyme rather, that converts T4 into T3, so T3 can be utilized by the cells, particularly the mitochondria of the cells, to produce adenosine triphosphate. And both of these T3 and T4 hormones are actually iodine based, and so therefore iodine is needed in order to produce T3 and T4. So you can probably deduce that a decrease in the iodine intake of the patient will cause decreased production of T3 and T4 that can lead to other condition, and we'll talk about that later. Okay, so Hypothyroidism, one of the disorder associated with the thyroid gland, is obviously under secretion of thyroid hormones. So hypothyroidism is technically defined as a decreased activity of the thyroid gland, producing slowness or sluggishness in mental and physical function of the patient. It decreases basal metabolic rate, and the patient will simply have no energy, and will complain of weakness all the time, feeling sluggish, feeling weak, simply because the patient doesn't have enough ATP production due to decreased T3 and T4 productions. Um, a lot of times, the cause of hypothyroidism is what we call Hashimoto's disease, and Hashimoto is a condition where um, the thyroid gland shrink or decreases in size because of some autoimmune disorders attacking the cells of the thyroid gland. The most extreme and severe stage of hypothyroidism is what we call myxedema or myxedema coma if it leads to comatose state of the patient. Okay, so Hashimoto's disease, which is one of the main cause of hypothyroidism, also called chronic lymphocytic thyroiditis or autoimmune thyroiditis, is an autoimmune disease. Um, this autoimmune disease actually attacks the thyroid gland, causing inflammation, interfering with the ability of the thyroid gland to produce hormones, particularly T3 and T4. Um, if you look back at the history of hypothyroidism, you will find out that, of course, this particular doctor, Dr. Hashimoto, found out that um some women, particularly in Japan, have this physical sluggishness and mental sluggishness as well. And he thought that it's just the culture, but he found out later that it has something to do with the energy production or ATP production of the cells caused by decreased T3 and T4 production by the thyroid gland. Um, so, how do we diagnose Hashimoto's disease? There are several ways of diagnosing Hashimoto. Number one is the TSH test or the thyroid stimulating hormone test. Um, 99% of the patient with Hashimoto's disease will have an elevated thyroid stimulating hormone in the blood, and it's almost always a sign of Hashimoto if you have above normal thyroid stimulating hormone levels in the blood, especially if the T3 and T4 are low despite of an elevated TSH level. The T4 test is or thyroxine test is also a diagnostic procedure that can be done just by obtaining some blood sample. And what will happen is if the thyroid stimulating hormone is elevated and the T4 or the circulating thyroxine sorry in the blood is sorry is low, then that suggests that the patient is having underactivity of the thyroid gland that can lead to the diagnosis of Hashimoto's disease. Anti-thyroid antibody test is another diagnostic procedure. This is when the blood will be tested and they will look for thyroid autoantibodies. And if they find some thyroid autoantibodies, then the conclusion is that these autoantibodies are actually targeting the thyroid gland, causing inflammatory lesions and interfering with the function of the thyroid, preventing secretions of these hormones. Of course, imaging studies like CT scan and ultrasound can be done as well in order to check the size of the thyroid and maybe look for some inflammatory lesions or inflammatory conditions. So, what are some signs of Hashimoto's disease? A lot of times, Hashimoto will cause problem in the wakefulness sleeping pattern or the diurnal pattern. Some people complain of insomnia or not being able to maintain, a good sleep. Brain fog, patient will be complaining of fatigue all the time, simply because they don't have enough energy. Uh, Widespread pain all over the body, and a lot of times stiffness of the body. There are two categories or types of hypothyroidism. One is called primary, if it is actually the thyroid itself that has the problem, meaning the thyroid doesn't have capability to produce adequate amount of T3 and T4, such as in the case of um, Hashimoto's disease. The other one is called the secondary type of hypothyroidism, and this is usually caused by malfunction not of the thyroid gland, but rather from the pituitary gland. So, if the pituitary is not functioning well and the pituitary is not giving or signals to the thyroid gland to produce T3 and T4, then obviously the thyroid gland will not release T3 and T4. So, any function of the pituitary gland, the anterior pituitary, will cause hypofunction of the thyroid gland as well. So, and this is what we call secondary type of hypothyroidism. So, a lot of times, again, like I said, for laboratory and diagnostic evaluation of hypothyroidism, a lot of times the patient will have decreased T4 and T3 level, but the thyroid stimulating hormone will be elevated. So in this case, it seems like the anterior pituitary gland is giving signals to the thyroid gland to release T3 and T4, but for some reason, the thyroid gland does not have the capability to release those hormones, and one of the possible reasons could be inflammatory lesions caused by Hashimoto's disease. You will also notice that the patient will most likely have an elevated serum cholesterol level because the body will have a very slow basal metabolic rate, again, secondary to decrease T3 and T4, thus reducing the amount of adenosine triphosphate utilized by the cells for cellular metabolism. If the patient is diagnosed with hypothyroidism, a lot of times the doctor will be ordering exogenous supply of T4 in the form of levothyroxine. I'm sure you're familiar with Synthroid. So the patient will have to take Synthroid in order to supplement, um, you know, T4, and that T4 it will be converted into T3. So the cells, particularly the mitochondria of the cells, can utilize the T3 to produce adenosine triphosphate. So let's look at other signs of hypothyroidism. Again, like I said, the patient with hypothyroidism won't be able to produce adequate amount of T3 and T4. Therefore, less production of T3 and T4 will mean less energy production, and so therefore these patients will always feel cold from the inside because there is not enough energy being produced by the cells. Therefore, not enough heat will be produced by the cells. So they will complain of being cold, even if it's the summer solstice, or even if it's too hot outside, they will still complain of cold. Um, they will have receding hairline, facial eyelid, maybe a little bit of edema around the eyes. Um, dull blank expression. They will have extreme fatigue simply because they don't have enough ATP production. Thick tongue. They will speak a little slowly because again, energy and the processing of information will be delayed a little bit. So there is a mental and physical sluggishness. um, they don't want to eat much because they will feel bloated all the time since uh, the food that they're eating will not be digested effectively and normally. Brittle nails and hair. They will have dry skin all the time. That's why they're carrying this body lotion all the time. For women, menstrual disturbances may happen. Um, even temporary cessation of menstruation, like amenorrhea. Because the basal metabolic rate is slow, therefore peristaltic movement will be slow as well. That causes constipation. Patient will complain of muscle aches and weakness. Again, dry skin. Patient will feel sleepy all the time. Decreased level of consciousness. So again, with that mental and physical sluggishness, they they will not have enough energy to utilize for mental functioning, um, and of course hair loss. Patient will have subnormal temperature as part of the late clinical manifestations. Bradycardia, weight gain, decreased level of consciousness, thickened skin. Uh, Right, sorry about that. As I was saying, patient will have some late manifestations or late signs like subnormal temperature. So, aside from being intolerant to cold, they are actually susceptible to mixed edema that can lead to decreased level of consciousness, even coma in extreme cases. So, this is what we call mixed edema coma. These are also the patients who will be eating less and less, less amount of food, but they will still gain weight. And this is simply because their body is not really utilizing the food that they're eating since they don't have enough or adequate amount of T3 and T4 in the blood. It may lead to some cardiac complications because of bradycardia, um, and it may even lead to congestive heart failure in some patients. So again, slowing of mind and body, mental and physical sluggishness. There will be bradycardia and weak heartbeat, constipation, mixed edema, high level of low density lipoproteins, and this is what I was telling you earlier about high cholesterol level. So these patients will be susceptible for some cardiac complications, coronary artery diseases, um, even to the point of MI and even congestive heart failure. They will have slow reflexes again because of physical sluggishness. So I don't think they will be really good boxers because of slow reflexes. Hair thinning, depression, schizophrenia, irritability, big tongue, croaky voice, dry skin, cold intolerance. These are just some manifestations of hypothyroidism. So, if you think about hypothyroidism, just remember this: everything is slow, um, and because everything is slow, they don't have enough production of adenosine triphosphate they don't have enough energy. They will have constipation. Peristaltic movement will be decreased, and so the food that they're eating will not be properly digested. It will not be properly absorbed by the body, and so again, they can eat small portion of food or serving, and they will still gain weight, and they will not produce enough energy. So they will feel cold all the time, and they will feel weak all the time. So if you think about that, it's easy to remember what are the signs and symptoms associated with hypothyroidism. All right, so flip um, let's flip it. Let's talk about hyperthyroidism. Hyperthyroidism is obviously hyperfunction of the thyroid gland, causing increased T4 and T3 production despite of the fact that thyroid stimulating hormone is low. A lot of times, hyperthyroidism is caused by or extreme cases or extreme conditions of hyperthyroidism can lead to what we call Graves' disease, and in some cases, emergency cases, it can lead to thyroid storm or thyrotoxicosis that causes nervousness, irritability, hyperexcitability, of course, palpitations, increased heart rate because of the increased basal metabolic rate, and everything is fast. Heat intolerance, these are the people who will feel warm, and they will feel hot all the time, even if it's like snowing outside. They will have diaphoresis as part of the compensatory mechanism of the body. Salmon color, so they're like almost red all the time. Why? Because the peripheral blood vessels will be dilated secondary to extreme heat or too much heat coming from the inside, causing vasodilatation, and so it will give them the salmon color skin. And in some cases, you will notice patient with hyperthyroidism, particularly Graves' disease, will have that exophthalmos, and exophthalmos is what we call exophthalmos is the bulging out of the eyeball, as if the eyeball is trying to come out of the eye socket. And so I'm sure you have seen some patients with exophthalmos like that. It looks like the eyeball is about to come out of the eye socket. So in these situations, a lot of times the management will be radionuclide or radioactive iodine. The patient will be asked to swallow some radioactive iodine in an attempt to decrease the production of T3 and T4. Of course, as a nurse, if you're taking care of a patient with hyperthyroidism, you need to observe for signs and symptoms of thyroid storm, basically hypothermia, extreme tachycardia, heart rate more than 110, sometimes 120, which is really really dangerous already. And of course, because of extreme tachycardia, less amount of blood will be coming out of the aorta, and it will decrease not just the stroke volume, but the cardiac output as well, causing decreased supply of oxygen to the brain, leading to decreased level of consciousness. The drug of choice for hyperthyroidism will be your propylthiouracil or PTU, or brand name Propofol, or there is another one called metimazole or tapazole, which is really really good in blocking the conversion of T4 into T3. So with metimazole or tapazole, it will block the conversion of T4 into T3, causing decreased T3 available for the cells to produce adenosine triphosphate. So, for extreme cases of hyperthyroidism, We call it thyroid storm, and watch out. You have to watch out for tachycardia, extreme heat coming from the inside of the body, and a lot of times this hyperthermia will not be controlled by usual anti-fever drugs or anti-hyperthermia or anti-pyretic drugs. um, you need something a little more stronger or a little stronger than just Tylenol. um, so it can cause altered level of consciousness also. So the goal is to reduce the body temperature. Some hospitals are using hypothermia blanket, ice packs, and then hydrocortisone, and of course acetaminophen. Now, acetaminophen, it's clear that we will use acetaminophen in order to help reduce the body temperature. I guess my question right now is why hydrocortisone? Um, why a steroid for patient with thyroid storm? And yes, you're right. Hydrocortisone is used or needed for thyroid storm because again, if you remember, thyroid storm or hyperthyroidism is a form of immune antibody response, and so therefore you need to depress the immune system in order to prevent this thyroid storm or thyrotoxicosis. So if you depress the immune system, then the function of the immune response will be depressed, decreasing the body temperature, and of course decreasing all the heart rate and signs and symptoms associated with thyrotoxicosis. So a lot of times acetaminophen will not be enough. You need to make sure that the patient will be given hydrocortisone as well. Um, all right, some signs and symptoms of hyperthyroidism. Again, one of the pathognomonic, or I would say classic sign of hyperthyroidism will be intolerance to heat. They will feel hot all the time, fine straight hairs, bulging eyes, such as in case of exophthalmos, facial flushing, like causing the salmon color because of vasodilatation of the peripheral blood vessels. The thyroid may be enlarged, causing a little bit of goiter. I'd like to emphasize goiter is not initially caused by hyper nor hypothyroidism. But a lot of times, if the patient has hyperthyroidism, then you will notice that it would cause enlargement of the thyroid gland as well. Tachycardia, increased systolic blood pressure, and you will notice that in hyperthyroidism, the systolic blood pressure will go up, leaving the diastolic behind, and it will create a widened pulse pressure greater than 40 millimeters of mercury. Some people will have enlargement of the breast. People will have weight loss. Why weight loss? Well, simply because the patient will have a very fast basal metabolic rate, causing too much expenditure of energy and of course ATP. Muscle wasting. Patient may have localized edema. It can lead to menstrual changes like amenorrhea. Instead of constipation, the patient will have diarrhea, tremors, finger clubbing because of hypoxia, and patient will not feel good either. So both hyper and hypothyroidism um, is simply will put the patient in a condition where they don't feel good all the time. I was telling you something about the effects of blood pressure to or the effects of hypo or hyperthyroidism to the blood pressure. I'd like you to remember that in hypothyroidism, a lot of times the diastolic pressure or the diastolic number becomes higher, maybe greater than 90 millimeters of mercury, but the systolic blood pressure will remain like in the 120s, 125. So what will happen is, if the systolic blood pressure remains in the 120s, 125, but the diastolic pressure goes up, then it will create a narrow pulse pressure, maybe less than 30 millimeters of mercury. In hyperthyroidism, the systolic blood pressure goes up, leaving the diastolic behind, creating a widened pulse pressure. So, two things that you have to remember. In hypothyroidism, it will create a narrow pulse pressure because the diastolic pressure goes up. In hyperthyroidism, it will create a widened pulse pressure because the systolic blood pressure goes up, leaving the diastolic behind. Um, okay, so I hope it helps you with with your NCLEX review. Uh, Now I have some questions here that may be helpful in understanding this further and putting all of these concepts and topics in perspective. Let's look at some of the NCLEX questions that we have right here. So, number one, the nurse teaches a patient with newly diagnosed hypothyroidism about the need for thyroid hormone replacement therapy to restore normal thyroid function. Which thyroid preparation is the agent of choice for thyroid hormone replacement therapy? We talked about this earlier. So, a patient with hypothyroidism, if the thyroid gland is not capable of producing adequate amount of T3 and T4, then you need to give exogenous supply of these hormones in the form of thyroxine, and the most available, or the most popular medication available in the market, of course, is your levothyroxine sodium, or simply your Synthroid. Um, Liothyronine, or cytomel T3, is not usually, it can be given, but to a certain extent, because again, you need the hormone that can actually convert T4 into T3, and T3 will not be, if you give exogenous supply of T3, then it's not gonna be utilized by the mitochondria of the cells. Um, all right, next. When assessing a client who has hypothyroidism, a nurse would expect to identify which of these clinical manifestations. All right, so hypothyroidism, think about this. Hypothyroidism, less T3, less T4, less energy production, less ATP production. So what will happen? Everything is slow, right? So will I have problem with will I have problem sleeping? Yeah, possibly. Diarrhea? Probably not diarrhea. I will probably have constipation. Weight loss? Probably not weight loss, but weight gain, because, again, decreased basal metabolic function. Intolerance to cold weather, that's pathognomonic of hypothyroidism. So, between difficulty sleeping and intolerance to cold weather, which one will be a better option? I would say D. Um, this difficulty in sleeping is partly hyperthyroidism, but again, insomnia, which is also a sign of hypothyroidism. Um, you might see some insomnia in patients with hypothyroidism as well. But between A and D, I would choose D rather than A, because, again, D is exclusively, a hypothyroidism symptom, and the exact opposite of hyperthyroidism. In hyperthyroidism, you might also see some issues and problems with the urinal pattern, but not because they have decreased level of energy, but because they have too much heat coming from the inside. Okay. Number three, a 73-year-old patient has been diagnosed with Hashimoto's. Hashimoto's inflammation of the thyroid gland caused by autoimmune response. So remember, that can lead to decreased production of thyroid hormone as well. The nurse will most likely observe which of the following set of signs and symptoms from the patient. So Hashimoto's, hypothyroidism, everything is decreased. Will I have weight loss? Probably not weight loss. So I will immediately remove A. I will immediately drop B because it has weight loss. Then I only have two other options left, C and D, because both of these will have weight gain as part of the option. Now, let's see. Will I have weakness in hypothyroidism? Yes, I will have weakness in hypothyroidism. Increased urination? Probably not, because again, everything is low in hypothyroidism. Constipation? Yes, I will have constipation. Purplish red stria and weight gain, not a good combination, but C will be a better option for me. I have weight gain, I have weakness, and of course, because of decreased basal metabolic rate, decreased peristaltic movement, I will have constipation in hypothyroidism caused by Hashimoto. So I would go with C. Okay. Number four, when caring for a client who is being treated for hyperthyroidism, which action is most important? When caring for a client who is being treated for hyperthyroidism, which action is most important? So we're talking about hyperthyroidism. What action by the nurse is most important if you're caring for a client with hyperthyroidism? So let's look at the options. A. Providing extra blankets and clothing to keep the client warm. Probably not for hyperthyroidism, because again, the patient already has too much energy, too much heat coming from the inside, so the patient will not be complaining of being cold, or they don't need to be warm. They actually need to cool down, or they need something to help them, feel cold, because they have too much heat coming from the inside of the body. Monitoring the client for signs of restlessness, sweating, and excessive weight loss during thyroid replacement therapy. That sounds good, but let's look at the other options. Balancing the client's period of activity and rest. That's a good option as well. Encouraging the client to be active to prevent constipation. Patient will not have constipation, so I will immediately drop A and D, because these uh, two are, nursing interventions for patients with hypothyroidism. So I will be focusing more on B and C. Monitoring the client for signs of restlessness, sweating, and excessive weight loss during thyroid replacement therapy. If the patient is taking thyroid replacement therapy, then most likely the patient will not have excessive weight loss, since you're already replacing T3 and T4. So most likely the patient's weight loss problems or issues will be minimized. But balancing the client's periods of activity and rest, I think this is very, very important, because you have to remember that the patient is utilizing too much energy, and so the activity and the patient's rest will have to be monitored, and it has all the patient's activities must be scheduled in order to maximize the patient's energy. So see, it says a client with hyperthyroidism needs to be encouraged to balance periods of activity and rest. Many clients with hyperthyroidism are hyperactive and complain of feeling very warm, consequently keeping the environment cool and teaching the client. So again, like I said, you know, B and C are obviously good options, except that this part of option B that says during thyroid replacement therapy, I don't think the patient will have excessive weight loss during thyroid replacement therapy, because you're already providing exogenous supply of T4 to the patient. So between B and C, uh, C would be a better option. Number five, a middle-aged female complains of anxiety, insomnia, weight loss, inability to concentrate, and eyes feeling gritty. Thyroid function tests reveal a low level of TSH and elevated T3 and T4. So if TSH is low and T3 and T4 are still high, then I will be thinking, oh, the problem is the thyroid itself causing hyperactivity of the thyroid gland. So most likely I'm dealing with hyperthyroidism. So based on this assessment findings, the nurse would suspect which of the following. Is it thyroiditis? Probably not, because thyroiditis will cause hypofunction of the thyroid gland. Graves' disease? Yeah, that's a good option. Hashimoto's? Hashimoto's thyroiditis and thyroiditis is the same banana. So I will easily drop both A and C. Multinodular goiter, again, like I said, goiter has nothing to do initially with hyper or hypothyroidism. So I would go with B. All right. So Graves' disease is an autoimmune disease causing hyperthyroidism. So there you go. I think that's all I have for you. I hope it helps you with your NCLEX preparation and NCLEX review, and I will try to produce and post one or two video lectures like this, focusing on different conditions and disorders, and hopefully it will help you with your NCLEX preparation. We will continue to do this until everybody pass the board. All right. Thank you very much. Until the next video lecture, you have a good day. Bye bye.